So welcome once again, everyone, to the second webinar in our Pediatric Radiology for the World series. This is the second one on the roll. The first webinar in this series was organized and led by Dr. Dorothy Bullis, Dr. Joanna, and Dr. Sanjay Prabhu on 20th Feb last month, and it was a great success with nearly 1,200 registrations. So welcome you all in your own different time zones across the globe. So I would like to briefly introduce the World Federation of Pediatric Imaging to our audience before we start this wonderful talk by Dr. Joanna Brown. So World Federation of Pediatric Imaging provides an international platform for pediatric radiology organizations to address the various challenges in global pediatric imaging training and delivery of services. It has commenced a lot of initiatives, including educational programs, outreach, TB group, MRI protocols, and fellowships all over the globe, specifically in areas that may be resource limited, to promote and build pediatric radiology in far off places. And there is a YouTube channel as well on the World Federation of Pediatric Imaging, Pediatric Radiology Academy, which you can access. I would like to specifically mention for our residents and budding pediatric radiologists about the WFPI 3 months fellowships, which is sponsored by WFPI and provides financial assistance to the selected observer. You can visit our website, WFPI website, for more details. Coming back to this webinar, we have nearly 700 registration this time, and it is rising as we speak. And for those who want to revisit this WFPI talk by Dr. Joanna Brown on ultrasound of the appendix and small bowel, you can tell your friends and colleagues also. We are going to repeat this on YouTube. The repeat telecast shall be on March 27th at 7 a.m. GMT time. Also, feel free to put your questions during the webinar in the Q&A box during the webinar. In the Q&A, just add your question and the place from where you're coming, right? And we should try to answer all your questions at the end of the session. So I'm happy to introduce our esteemed speaker for this webinar, Dr. Joanna Brown, who is the president of World Federation of Pediatric Imaging, who shall be speaking on a very important topic, ultrasound of the appendix and small bowel. Dr. Joanna Brown is Senior Consultant Radiologist in the University of Bristol, United Kingdom. Her work includes pediatric and oncology imaging with special interest in pediatric MRI and functional cancer imaging. Dr. Brown is the President of World Federation of Pediatric Imaging and current Chair of Outreach Committee of the European Society of Pediatric Radiology. She's wearing many hats. She's an executive member of British Society of Pediatric Radiology and chairs the BSPR Pediatric MRI Committee. Very passionate about global radiology, Joanna is a member of the International Committee, the Royal College of Radiologists, London. She has been actively involved in many international projects in Africa, Asia, and Europe. As a radiology expert and senior consultant for the United Nations, World Health Organization, and IAEA, Dr. Brown has numerous publications and has been invited as guest and keynote speaker to many international and national conferences and various educational courses in UK and abroad. Over to you, Dr. Joanna Brown.
Great. Thank you very much for this fantastic introduction. We really don't earn it, but thank you very much. And I would like to say good afternoon in UK and good morning, good evening to everyone who is joining our webinar today. And today I'm going to talk about the ultrasound of the appendix and the small bowel. It's not a very easy topic, but I hope that I will convince you during the next hour that it's very useful and we can all do it. And as my friend Professor Sodhi said, I'm involved in a lot of MRI projects, and I really start imaging in the beginning of my career small bowel with MRI, and then start thinking maybe something else that we can produce and offer. So appendix and the small bowel. Small bowel is really difficult to image because you all know from anatomy that it's very complicated structure. It's very, very long, between 3 and 5 meters in a living person, much longer in the cadavers, and all of the loops of the small bowel are really being pushed together and very squashed, very, very close to each other in the abdominal cavity, as you can see on the picture. We will think that appendix is much easier to image because it's usually positioned in the right iliac fossa. But if you look at the anatomical picture, the position of appendix can be everywhere. And the normal appendix moves in the human and in the child. It can be one's position in the pelvis, and the second then you can find it in the different positions. So not very easy task to in front of us. As we all know, CT, it's very, very easy and very useful in imaging of the small bowel. We can go and give the positive oral contrast or negative oral contrast, but we all know that includes ionizing radiation. MRI, again, easy to look at the small bowel, but in children, this is and in adults as well, it's a very long examination. So if we have to keep our pediatric patients still for a long time, this is a significant challenge. So can we look at the small bowel and the appendix with ultrasound? So what do we need to do to start? We need to have a normal curvilinear probe between 5 and 10 megahertz. We need to start always with a probe with a higher frequency, then decrease frequency if it's not enough penetration, if we want to look at the abdomen and the lobes of the small bowel. We need to examine all abdominal organs starting from the right upper quadrant, mainly because it may be different pathology which is presenting with the abdominal pain. Then I usually go and use the high frequency linear probe to examine the bowel. I always apply the gentle pressure and pushing the bowel away to improve visualization and look at the deeper structures. So when we look at the bowel, what can we assess? We can assess the thickening of the wall. We can look at the wall layers and vascularity, lesions or cysts related to the bowel loops, free fluid or abscess formation, bowel motility, or bowel contents. It's very good with looking at the congenital malformation, at the inflammatory bowel disease, obstructions, or soft tissue lesions. So a couple of slides about the normal appearance of the bowel. When we look in the bowel in details, we can see on the ultrasound 5 different layers of the bowel wall. Superficial mucosa, when we have inside the more inner structure and layer, and you can see it here in the mid part of the image. Sometimes, if the lobes of the small bowel are filled with air, this can blur together with air bubbles inside. So in this situation, you need to change from the Kelvinier to the high frequency probe to improve the visualization on this level. Then we have a deep mucosa, which is black or gray, submucosa, which is usually very, very prominent. You can see it as a bright layer, secondary to the amount of fatty tissue between the different structure and blood vessels in this layer. Then we have a muscularis propria, when you see again when it's black, and then serosa, which is white again. We need to remember that the bowel will look different, depends how much the lobe is distended. So this is a normal appearance of the jejunum when the bowel is collapsed. And you can see here how folded the mucosa is inside the bowel lumen. If the bowel is filled with fluid and with air, as you can see it here, the bowel loop will look completely different. But in both situations, we need to be careful and we can see all 5 layers of the bowel wall. Also, we need to remember that the small bowel, it's not the same. We have a first part, jejunum, which has a completely different structure to the ileum. We have more mucosa villi inside, we have more vessels, we have a different histological appearance, which will recommend and corresponds to the different pictures on the ultrasound. And you can see here on the left, normal appearance of the jejunum and the normal appearance of the ileum. So again, depends where you will put your probe during your examination, you will see a difference. And the word about the large bowel, again, the large bowel look completely different. We will know that we are over the large bowel because the main position of the loops of the bowel, but we can also see the different appearance on the ultrasound. So the muscularis will look completely different. We will have a free longitudinal tenia and the different structure of the bowel. So again, we need to be aware of the different appearances, normal physiological appearance. Ultrasound appendix. It's one of the most common ultrasounds examination of the abdomen performed in children. We usually use the high frequency linear probe between 7 and even 14, 15 megahertz, or curve probe. We start in the right iliac fossa over maximum tenderness. We should be using graded compression technique. And also we need to remember about the lateral and posterior approach for retrocecal appendicitis. So how do I do the ultrasound of the appendix? I usually go onto the right side of the abdomen and try to find the cecum in the longitudinal view. Then cecum may look like on the previous scan, which is filled with fluid. It will have this appearance. However, if it's filled with air, this is what you may see on the right side of the abdomen. Not much, because the posterior part of the cecum will be obscured by shadowing from the intraluminal gas. Then I turn my probe transversely and I will try to find the terminal ileum and ileocecal valve. We know from the anatomy that appendix is located below the ileocecal valve, and then it depends on the patient because it's quite a wide physiological variance between 2 and 4-5 centimeters below the ileocecal valve. Then we will try to find a blunt ending and easy compressible structure in the right iliac fossa. Very often when people start scanning for the appendix, they are looking really, really deep into the pelvis. But in the children, especially very skinny and slim children, appendix will be located just under the anterior abdominal wall. You can see here a few examples of the normal looking appendix. Blind ending structure, fully compressible during the ultrasound examination. So how do I know it's appendix? It's a small tubular structure, as I said, is easily compressible. If you leave your probe over the appendix, you shouldn't see any peristalsis, and there are no changes in appearance of the appendix over time. Then appendix may contain fluid or the fecal material and should be less than 7 millimeters in diameter. The thickness of the appendix wall is usually between 3 and 5 millimeters. Some people, and in some of the articles, the limits, the upper limit of normal is 6 millimeters for the wall of the appendix. Usually we accept that between 7 and 15 millimeters is thickening, which is pathological appearance. However, in my practice, if I see that the appendix is about 7 or 8 millimeters, but it's compressible and the child hasn't got any symptoms, I will comment it on my report, but I wouldn't call it appendicitis. Then, if we have the inflammation of the appendix, apart from the thickening of the bowel wall, we will have the incompressible structure, because it's all of the inflammatory infiltration within the bowel wall make it incompressible. Then we will have a focal tenderness and increased Doppler flow with our imaging on the ultrasound. In about 30% of the patient, we can see calcifications within the appendix causing shadows, and this will be consistent with the fecolite. Secondary site of the acute appendicitis will be a free fluid in the area adjacent to the appendix, in the right iliac fossa or in the pelvis, and we will have a layer of the echogenic fat around and along the thickened appendix. And you can see here on this picture how much is abnormal looking fat in the surrounding area. And another few examples with the echogenic fat around here. If I go into the previous one, you can see here that the echogenic fat is around here, but the appendic wall is very, very well defined. So this is like a moderate inflammation of the appendix, if you want to grade it. This example shows slightly more advanced inflammatory changes. You can see the echogenic fat around there, but the walls of the appendix cannot be very easily visualized, and this is much more advanced inflammatory changes in the structure. And you can see it here with a little bit fluid. You can't really see the proper walls of the appendix, fluid around, which is probably suggestive of perforation and forming appendiceal abscess. And again, very, very echogenic fat in the right iliac fossa in the surrounding area. Then we can have enlarged lymph nodes in the area of the appendix, and usually due to appendicitis, they will lose this characteristic structure. So they won't be oval in shape, they won't be having a fatty hilum. We need to be very, very careful because we know that some of the children will have a small, normal physiological looking lymph nodes in the region of the terminal alien, and this is a normal physiological variant. So look at the size of the lymph nodes and the lymph nodes structure. Then, very often with the ultrasound, we can see the rupture of the appendix, as I show you on the previous scan, the early rupture, or building here, as you can see it, building of the abscess with a irregular and very heterogeneous fluid and septations within focal collection. So all of this is really nicely seen and can be found with the ultrasound without the need of doing CT or MRI on these patients. Then we also need to think about a differential diagnosis, because they can be different imaging, different pathologies than acute appendicitis. We can have a mesenteric adenitis that you can see here, example before on this slide, but very often when you have a multiple enlarged lymph nodes, there will be lymph nodes scattered through the mesentery, not only visible in the right iliac fossa, which are more characteristic for acute appendicitis. We can have the infective ileocystitis from the different regions, from the different infection with the bacteria, viruses from the TB. Then we have a mural inflammation. Very often is a lack of the fat edema and the proliferation of the fat in the surroundings of tissue. We will have again increased lymphadenopathy, and the most important, we will be able to visualize a normal looking appendix. Then a very unusual or not very commonly seen appendix lymphoma. But if we have the lymphoma, we will have the different history of the patient, very often palpable or visible mass, both on the ultrasound, peritoneal disease, and lymphadenopathy. This was one of adult patients that presented with a very typical history of acute appendicitis. And when we've done a ultrasound, we found this cystic structure in the right iliac fossa. And because the surgeons were absolutely adamant it's acute appendicitis, we were not sure if this is the cystic or collection. We proceed to MRI and found the abnormalness. However, I like to stress it that it's not really necessary to do the MRI in children or in any patient if we have a diagnosis performed and on the ultrasound. On MRI is much more difficult to assess due to peristalsis of the adjacent lobes, and very early appendicitis, it's much easier to see it on the ultrasound than on MRI. We also can have a Crohn's appendicitis. It's not happening very often, but I have a few patients that presented as acute appendicitis, and this was a first presentation of the Crohn's disease. And the ultrasound is incredibly valuable here to differentiate between the normal acute appendicitis and appendicitis due to the Crohn's disease, and we will discuss it in the next slides. You can see here that with the Crohn's appendicitis, you have a thickening of the different layers of the bowel. So ultrasound is your great friend in differentiation of these two diagnoses. Then we can have a intussusception that can mimic acute appendicitis, and again, ultrasound is a great tool in this examination. It can be also renal abnormality or ovarian pathology, which can present with the acute pain in the right iliac fossa. And again, we will be able to visualize these abnormalities with the ultrasound. So let's move into Crohn's disease. Crohn's disease in appendix, not very common, but Crohn's disease in the small bowel, especially in the terminal ileum, I found it in my practice that it's increasing in frequency, and we have younger and younger children presented with this disease. So what we are looking at? We are looking at the wall thickening in the terminal ileum or in any part of the small bowel, and the wall will be thickened more than 6 millimeters, usually between 7 and 8 millimeters. And as you see here, it's a typical presentation of the Crohn's disease on the ultrasound. Why is it typical? I will cover it in a minute with a expression and looking at the different layers of the small bowel. Wall thickening can be, as you know, in the Crohn's disease, can be only in some segments with a normal looking bowel between, or as the Crohn's disease progresses, we will have a very diffuse long segment disease, which again, it's very easy to identify on the ultrasound. Why it's different to the other infections? Because we in Crohn's disease, we have a loss of wall stratification, as you can see it on these images, but layers of the bowel are very relatively well preserved. So you can see here the white layer of the submucosa. Then you see the darker layer, and then you can see the mucosa, which is very, very thick and it's very, very irregular. And this is usually the layer which is the most commonly affected in the Crohn's disease. Again, here looked at this very, very abnormal looking look of the small bowel, but again, the layers of the small bowel, of the bowel wall are preserved. And this is different because when you've seen before the pictures of the abnormal looking appendix, all of the layers have been completely blended together. You can see the thickening of the bowel wall, but you cannot differentiate between the different layers. And as in any inflammation, we will have decrease in the blood flow, but again, you have increased blood flow in this white looking layer of the bowel. All of the other loops, even if they are thickened, the blood flow in the other layers won't be as high or as increased in the layer of the mucosa. And we have also hyperemia of the bowel wall, which is represented by the increased blood flow, and we have increased echogenicity in the adjacent mesentery. Again, very, very important to look at the mesentery in the Crohn's disease because we can help differentiate between the acute, subacute, and chronic changes. And common signs in the mesentery, this was the signs that we were seeing on the different imaging techniques, especially on the CT and MRI. But in the advanced Crohn's disease, we can see these features also on our ultrasound images. Looking in the changes in the mesentery, similar to any long-standing infection or inflammation, we will have an increased vascularity, as you see here on these images, and we will have a really massive proliferation of the mesentery, as you can see it here, with a lot of fatty changes and increased echogenicity, and the lobes of the abnormal bowel, and you can see here, they will be separated and pushed away from each other on the scan by this very abnormal looking mesenteric fat. Again, one of the other features of Crohn's disease. Then we can also look at the lumen narrowing, we can identify, as I showed you on the previous scan, very long segment strictures or a short segment strictures. What is really important with the ultrasound, that this is a dynamic examination. So it means that if we put our probe and leave it on the segment which are normal and what is strictured, we can have a look if the peristalsis is progressing through this segment or not. This is one of the really important questions that our clinical colleagues ask us. Our surgeons want to know if the peristalsis is passing through the stricture or not. If the peristalsis is going through the stricture, then this patient can be treated in the conservative way, and we will give the inflammatory drugs, steroids, and all of the new treatments for Crohn's disease. However, if we don't have a peristalsis, it means that changes in the Crohn's disease progressed. There are only fibrotic tissues there, and it means that the patient will need to have a surgery. So very important features that we can answer with the ultrasound. Then we can look at the segmental dilatation proximally to the stricture. Is it a partial obstruction? Is it a total obstruction? Do we have any peristalsis in the remaining part of the bowel? We can always assess contents of the bowel. Is it a fluid or is it a fecal tissue? Then, with a progression of the Crohn's disease, we can look at the irregularity of the mucosa, and we can also see the inflammatory polyps that you can see here, these little irregularities of the adjacent mucosa. And in the healing phase, we can look at the ulceration of the bowel loops. And again, ultrasound is a relatively quick examination, and we can repeat it several times in our patients and assess the changes which that are happening within the bowel wall during treatment of our patients. Then we can look at the fistula formation in the advanced Crohn's disease, and with a focal collection adjacent to the fistula formation. Finding fistulas are relatively difficult on the ultrasound, but with the experience, you will be able to find it with the experience and the patience of doing the scan. Unfortunately, sometimes can be quite a long time. But if we can avoid doing CT or repeating MRI on this patient, it's very, very useful. And then we can also find in more advanced disease focal perforation, as you can see here, with collection and the abscess formation. And sometimes you can just see here, when you put the probe and leave the probe over the area of the collection, you can see the extension of the air within the loop of the small bowel into the collection, and you can demonstrate fistular tract in this area. So this was a Crohn's disease. We can also look at the bowel with an acute infection or any other origin. And if I go back into the Crohn's disease, and you will look again into the layers of the small bowel that are preserved, and you can look now into the acute infection, you can see it, that layers here are all blurred together. So very often this is an important features at looking at the other acute infection of the small bowel. Where else are we doing the ultrasound? Intussusception. It's our choice of examination now in looking at the intussusception in children, and everyone knows it. It's a donut site, very, very typical, very easily find with the ultrasound. We have a bowel wall thickening. We can see the separate layers of two bowel walls, and we will have the increased vascularity. Again, vascularity is really important in our examination because this will show the surgeons and the clinician if the bowel is still valuable. If it's the increased blood flow, then we can attempt the air reduction. If the blood flow is not existent, it's much higher risk than the bowel is already start developing necrosis and the child will need a surgery. Very often we can see a leading point in the intussusception. As you can see here, this polyp lipoma within the bowel wall, and this was the examination performed on the teenager. Because it was in the adult hospital in the middle of the night, the CT has been performed first, but ultrasound will give us all of the required information. And then is another patient showing a lipoma of the ileocecal valve. Again, very nicely and beautifully demonstrated on the CT, but we can see exactly the same information using the ultrasound examination. And we can also look at the wall edema with the decreased vascularity. And again, this is beautifully seen on the ultrasound. We don't really need to have a CT to confirm this diagnosis. And important, as I said before, looking at the blood flow within the bowel wall, because this is important for patients' management. And this is one of my patients, and this patient presented with several episodes of the abdominal pain. And each time when we scanned him, we found multiple intussusceptions within the abdomen. And this child, after several episodes of increasing pain, went under surgery, and we found that this patient had the angiodysplasia, multifocal angiodysplasia in the small bowel, which were the leading points of these vascular lesions, taking and pretending to develop the recurrent and multifocal areas of intussusception. And now another pediatric emergency that ultrasound is helpful is a malrotation. So when we have a baby presenting or a child presenting with the bilious vomiting, we all know it's the emergency. We don't have much time and we need to exclude a malrotation. Upper GI contrast study is our examination of choice to show the abnormal position of the duodenojejunal flexure, but ultrasound can be helpful. Ultrasound will show us a reversal position of the SMA and SMV. There are several articles published on this subject, and for some time we were very happy that we can diagnose the malrotation with the ultrasound, but a multi-center study showed that if we see the abnormality, that's great, but if we cannot demonstrate it, the child will still need the upper GI contrast study. So upper GI still is our first examination of choice. What can we see on the ultrasound apart from the swap of the position between the SMV and SMA? We can see the whirlpool sign, and you can see it here. So this is swelling of the SMV and small bowel mesentery around the superior mesenteric artery. We can see the decrease or absent perfusion within the bowel wall, or with a progressive changes, we can see a pneumatosis within the bowel wall. But again, remember, our upper GI contrast study is our first examination of choice. When we talk about the pneumatosis coli, necrotizing enterocolitis, for many, many years, plain X-ray was the great examination in assessing the patient with necrotizing colitis. And this is still our first examination of choice. But ultrasound is really increasing the use in this image, in this pathology. What we can see on the ultrasound? We can see the bowel wall thickening, we can see a bowel dilatation, and we can look if the bowel is moving, is it showing any signs of peristalsis or not. But probably this examination we can find on the clinical examination of the baby and on the X-ray. But what is really important for us is to look at the increased wall echogenicity, because it will show us how advanced is the necrotizing enterocolitis process within the bowel wall, and also look at the air within the bowel wall. And we can see, as you can see here on this example, multiple small loops, this increased echogenicity within the bowel wall, which has like a bubbly appearance. And this is characteristic of pneumatosis coli. We can also look at the liver and look if it's any evidence of the portovenous air. Ultrasound is more sensitive for air within the portovenous system than a plain X-ray. And the most important feature is that we can look at the flow of the blood. If the blood flow is persistent with necrotizing enterocolitis, it means that the bowel is still viable and the child will be treated in the conservative way. If we don't see any blood flow, it means that unfortunately the necrosis is developing in the bowel and the child needs to be treated in the surgical way. We start doing ultrasound in necrotizing enterocolitis very, very often in our neonatal intensive care unit, mainly because we can assess the progression of the changes within the bowel. So we can measure the wall thickening, we can measure and assess how much air is within the bowel wall, and we can measure the blood flow. It's much more sensitive examination than the X-ray. X-ray is easier to obtain, especially in the middle of the night, but the ultrasound is more sensitive and we can help our clinicians. And of course, ultrasound hasn't got any ionizing radiation. And if we don't see any blood flow in a very changed and very abnormal loop of the bowel, the child will need to have a surgical treatment. We also can see a vasculitis and looking at the small bowel edema. As you can see it here, increased water content within the bowel wall with a really beautiful images. And this patient, it was teenager, had the CT performed because the surgeon didn't believe us, but I think that the images of the ultrasound are fully diagnostic and the CT wasn't necessary in this patient. Ultrasound of the small bowel is also important with looking at the bowel obstruction. We can see it from the X-ray if the bowel is dilated, is it the small bowel or is it the large bowel, but really X-ray or even CT doesn't really tell us anything about variability of the bowel and its motility. Is it the real obstruction or is it alias? So what we do in this patient, we just put the probe over the loops of the dilated bowel and we look if the bowel shows any peristalsis or not. If the peristalsis is there or is increased peristalsis, it means very often that this will be a real obstruction because the bowel tries to overtake the obstruction in the more distal fragment. If there are no peristalsis, this is most likely due to alias because there are no functionality and motility of the bowel. So this was a very short overview of the ultrasound, how we can examine the bowel and appendix in our pediatric patients. There are several lectures and the courses, both theoretical and practical, how we can improve our ultrasound. But I will really encourage everyone to start using ultrasound and looking at the bowel. When you start doing it in the beginning, it looks very difficult and complicated, but doing this and doing more and more examination, it will be much easier. And I hope that during this lecture, I prove you how useful and important is this examination in multiple different conditions and looking at the abdominal pain in children and diagnosing different pathologies related to the small bowel and appendix. So thank you very much for your attention. When you look at the bowel loop, please remember to look at all of the contents, wall thickening, motility, vascularity, and I'm sure that you will find this examination very, very useful. So thank you very much for attention, and we can start the discussion. Thank you.
All right, thank you, Dr. Joanna, for an excellent overview of a very important topic, ultrasound of the appendix and small bowel, and you have raised a lot of interest on applicability of ultrasound as well in this region. We have a lot of questions from the audience, so we can start one by one. The first one is by Dr. Nareka from Africa. He says, aside from preserved bowel signature, kindly go through other key ultrasound findings which help you differentiate Crohn's disease from other inflammatory diseases.
I think that the most important, what I try to show it to you, that very often we will be guided by the clinical history, if it's the Crohn's disease or is it other infective disease, because very often the clinicians will be able to tell us which way they are thinking it's more common. But we all know that the Crohn's disease, the most commonly starts from the terminal ileum, and the terminal ileum is the most common part of presentation. And as I show you before on my screens, with a Crohn's disease, the most important feature is that you have layers of the small bowel preserved. So it means that you have very often thickening, irregularity of the mucosa, but you still can see the difference between the mucosa muscularis and the submucosa. So this is the most common differential diagnosis in Crohn's disease. And then you can look through the segmentation. You know that that Crohn's extends more proximally, but part of the bowel can be normal. So it can be normal segments of the bowel between the affected bowel. This will also guide you towards the Crohn's disease, when in the other infective pathology, it will be more than the whole bowel will be infected. So mainly look at the layers of the bowel if you can still and differentiate the different levels in this very abnormal inflammatory or infected process.
Sure. We have a question from Dr. Ajay D'Souza from Al Jalila Children's Hospital, Dubai, UAE. He thanks you first of all for an excellent talk, and he wants to know if you run a separate ultrasound clinic for IBD, and if yes, how much time it takes per case, and is it resource intense to get a dedicated ultrasound clinic running?
Yes, we have a separate, yes, we run this service. What we try to do in UK, we try to do it like a one-stop clinic for these children and young adults. So very often children will go to the clinic to see a gastroenterologist or pediatrician, and immediately after this will come and see us in the radiology. I usually book one patient for slightly longer scan, so between 20 and 30 minutes appointment. Saying that, as probably like everyone else, we train our sonographers to do different examination. And in my hospital, we have 3 sonographers who are being senior sonographers who are being trained especially in examining of the small bowel, and very often they're running the clinic for the IBD. I'm always, or one of the other radiologists is always around. So I have 3 or 4 sonographers scanning the same time, and I'm looking at the images. If I'm not sure if I'm happy about the quality of the images, or I would like to see something more, then I will go and scan the patient. It's definitely better to do the ultrasound than MRI, even with 20 or 30 minutes of your time. Is still a shorter time than putting the children for repeating MRI examinations. It's kinder for the children, and again, it's better because you have this dynamic examination of the bowel, of the peristalsis, and also you can record much better the blood flow and then compare the blood flow on the next examinations.
Okay. So we have a question from Dr. Mutinta Natini. What are the preparations needed for optimal imaging of the appendix and bowel? That is, do you do something so that you can optimally visualize the appendix and bowel beforehand?
Now, because very often the children with acute appendicitis, they will just present as the emergency in our A&E department. So we don't start the children; they will just come as they are coming to the hospital, and then we will perform the scan on these children. Very often with appendix, as I said before, remember about the different position of the appendix. if you need to apply the gentle pressure, you may need to move the adjacent loops of the bowel with your probe with a gentle pressure and moving them around, similar to the fluoroscopy that we've been doing it before. And very often just go and scan and put the probe in the different position, because the lateral or even inferior part, it may really help you to visualize retrocecal appendicitis.
Yeah, there was a question earlier for retrocecal appendix, and Sanjay has answered it. You just place the child in a 45 degrees left posterior oblique position and then scan sagittal positioning through the right flank. It really improves the visualization of retrocecal appendix,
Yeah.
So this yeah, go ahead.
Yeah, definitely. You can't just have a one position for doing the appendix. The most important advice is you just need to find your bearings. So this is why I always start looking from the cecum and trying to find the ileocecal valve. And then you just need to be aware that the appendix can be positioned anywhere. The most commonly will be lower and will be going into the right iliac fossa, but it's not always. And remember, one of the most common mistakes for people who start doing examination of the appendix, that they are just looking too deep. In children, appendix can be really positioned very superficially.
Okay. We have a question from Jandas de Villiers from South Africa. So when do you call it an appendiceal phlegmon? Do you use the term appendiceal phlegmon in your reports, or I think that is the question?
Yeah, I think that it really depends on your vocabulary and how do you communicate with a clinician. Yes, we can use the phlegmon, we can use the focal perforation. It's really, because when you do the scan, you can assess the appendix. Is the whole appendix abnormal? Or you, for example, can have only thickening and abnormality at the tip of the appendix. Sometimes, even if it's on the tip of the appendix is abnormal, you still can have a perforation and you have a collection there, or maybe the whole organ will be very, very abnormal. So yes, you can see you can say the phlegmon, you can see the focal perforation, you can say a adjacent abscess or the collection.
Okay. We have a question from Muhammad Yusuf, who asks, again, says great presentation, but the question is, do we routinely assess for Meckel's diverticulums as well in all appendix ultrasounds for acute abdomen?
Right, I found that Meckel's diverticulum, it's incredibly difficult to find on the ultrasound, and ultrasound, unfortunately, is not very specific for this examination. Because as you know, the Meckel's diverticulum can be really, really small. It should be the most commonly positioned or anti-mesenteric wall of the bowel, but this loop of the bowel can be anywhere, can be behind the different loops of the bowel. So I don't diagnose Meckel's diverticulum with appendix, with the ultrasound. When you see it, you are lucky, but ultrasound, it's not very sensitive.
Okay, so we have a question from Rayan Ahad, who asks, what is borderline appendicitis, and does CT or MR add any value or just confuse the picture even more? So do you do a repeat ultrasound, or you do a CT or MR for equivocal cases or some borderline appendicitis?
Right. A few years ago, when I started doing the ultrasound, 10 years ago more now, when I started doing ultrasound of the small bowel and appendix, because the surgeons wanted to know immediately in the situations that I wasn't sure or was it the borderline, I was doing MRI. However, from my experience, I found that very early appendicitis, it's difficult to see on the MRI because the adjacent loops of the bowel thickening, it's not very extensive and you don't have changes in the surrounding mesentery. So you haven't got this beautiful visualization on the MRI. So in my current practice, I will repeat the ultrasound, probably maybe the same day in the evening or the following day if the patient condition deteriorates. I don't know how it's in your country, but in UK at this moment, the surgeons are less and less keen on operating on the mild or even moderate appendicitis without any complications. And very often these children will be kept in the hospital for about 2 days for intravenous antibiotics, and then being discharged home on the conservative treatment. So we will always have time to do this examination. And if the appendix is very, if the inflammation is very advanced, then you will be able to do it on the ultrasound. So shortly, I will repeat the ultrasound instead of doing MRI. And CT, it's not really recommended in children because the radiation dose, and also children don't have a fat within the abdomen. So in adults, when you do CT, you can see the appendicitis because very often it's adjacent, it's around is a fatty tissue, so you can see it. In children, visualization of the normal or minimally changed appendix is very difficult.
All right, thank you, Joanna. So we have a question from Dr. Ramesh from Bangalore, from India, who asks your experience regarding the hypoechoic nature of liver, and does it correlate with the severity of appendicitis? Because Dr. Ramesh feels in his experience, he has noticed many cases in which the liver is more hypoechoic in ecotexture in cases of appendicitis. Do you have any similar experience on this?
No, maybe we just don't look at the liver during the same time, but I haven't noticed it in my experience. But it will be really useful, and if this is the recurrent pattern to know about this. But no, I haven't noticed any correlation between these two findings.
Yeah. Okay. All right. Thank you. So we have lots of questions. I'm trying to pick and choose now. All right, we have another question from Dr. Ajay D'Souza from Dubai. With what structure is bowel compared to, say, increased echogenicity, and how to say increased blood flow? Is there any objective criteria on color flow imaging and necrotizing enterocolitis, specifically ones?
Right. I always try to look at the you know, that is a big difference in the imaging of the different patients. What I try to do, you know, sometimes when you have if you're looking at the fatty infiltration of the liver, you compare it with the kidneys. It's really difficult to have this comparison between the different lobes of the bowel, between the different patients, because bowel can look really different in some children or some young adults that are slightly more, not obese, but if they have more fatty tissue, they will also have a more attenuation within the bowel. What I do I always examine several lobes of the bowel. So if I find the abnormality of the bowel wall, I describe everything, I measure everything, but at the same time, I compare it with the bowel which is not affected, or in my opinion, it looks normal. So then I have a comparison of the echogenicity. I don't measure it, it's usually mild, moderate, or the severe. What I do very often in these children, we do next examination and repeating examinations, and then because you have everything stored on your PAC system, then you can compare the different images. I don't measure any flow within the bowel wall as an array or any flow. It's usually what we do in our examination. We grade it between level 1 and level 5. And again, this is very subjective, but if you start doing, or if we do a lot of this examination, that our grading is it's more consistent.
All right, thanks. There was this question: how do you distinguish between small and large bowel on ultrasound? Is it always possible to differentiate that between the two, especially in cases of obstruction?
No.
And there is a similar question to it, which asks, how do you diagnose terminal ileitis?
Right. So differentiate between the small and the large bowel lobes. If it's in the normal patient, so if we don't have the obstruction, it's relatively easy, because then you can have a different structure of the mucosa, and you have a different structure and appearance of the muscle layers and the muscle orientation within the bowel wall, as I showed you on one of the scans. Then from the clinical perspective, the location of the large bowel is usually more lateral and superior to the small bowel. Large bowel will have fecal material and more air than the small bowel. But all of this, it's really very difficult within the obstruction, because if you have distended loops of the bowel, then the walls are being very, very thin, and you have a lot of fluid inside the bowel. So sometimes it's really difficult, and sometimes it's just not possible. But again, always look at the structure of the mucosa and the muscle wall within the bowel.
How often does mesenteric adenitis mimic acute appendicitis? This is a question from Dr. Jayaraj Govindaraj from Chennai, India.
All right, we have a lot of children with the mesenteric adenitis in UK. They usually present in the late autumn and in the winter. And this is kind of when we have the flu season here. So all of the adults present with the flu and the chest condition, and more often the children present with mesenteric adenitis. I would probably say that with a typical pain of the abdominal pain, central pain migrating to the right iliac fossa, we will see about acute appendicitis in about 2/3 of this patient, and 1/3 will have mesenteric adenitis. But again, they will have a lot of enlarged lymph nodes scattered through the whole mesentery, and also the clinical pictures. So CRP and white cells won't be as elevated as in a situation of acute appendicitis. So this can be your help as well.
Okay. So I have two similar questions, so I'm going to combine them together. So, but they're trying to ask, is there a lot of artifacts with ultrasound? So the one question is, by scanning a preterm neonates with NEC and distended abdomen, how can we overcome the image artifacts secondary to gases from distended bowel, which is quite a common scenario? And there was a similar one, which is also asking about a lot of artifacts from the abdominal gas. How do you go about it? Any tricks of the trade?
Right. First, in necrotizing enterocolitis, we all know how difficult it is to do this examination, and it's really difficult to sometimes to image the baby, mainly because very often sometimes you can reduce the amount of artifacts, so by reducing the amount of air within the lumen of the bowel. So you can do a similar procedure what we do for MRI. So ask patient to drink a lot of fluid before the examination. And again, drink it like we have a prep for MRI. So drink, for example, liter of squash or the juice or any water over an hour before the examination. It means that we hope that the loops of the bowel will be filled with fluid, and then we will limit the amount of air and then the artifacts. So this is possible in slightly older children. In babies with necrotizing enterocolitis, they are all on the IV nutrition, so we can't really give them any fluid into the bowel. So this reducing the artifacts is more difficult. However, in the clinical scenario, if we see a lot of artifacts, in the necrotizing enterocolitis, we can diagnose pneumatosis coli, so the air within the loops of the bowel, thickening of the bowel loops. We can all diagnose this one on the X-ray, abdominal X-ray. The really important thing is to look if we see any blood flow or not, and then it's we can only see it because if the bowel is going into the necrosis, very often it's quite a long segment of bowel. So we can look at the anterior wall of the bowel, then you can see it, even if you see the artifact behind. I change the different position of the baby. So sometimes you change the position of the baby, then the air will migrate inside the lumen onto the one side of the wall, and then you try to scan from the other side. So look at the part of the wall where it's fluid. So you need just to play with the position of the babies and different position of the probes, and again try to move gently the loops of the bowel around. I think that this is only.
Yeah, I think that is a very important trick of the trade. You have just pass on Joanna to do an ultrasound in different positions, right? In case you are kind of stuck at one point. Okay, so we have a question from Sani Usman who asks, a patient with right iliac fossa tenderness, there are enlarged lymph nodes and the appendix measures about 6 millimeters. So can we label this as appendicitis with no other findings?
Right, it's a very common scenario in our current practice. If I see abnormal looking lymph nodes, I will look everywhere in the mesentery. Is it no lymph nodes there at all? And the appendix is about 6 millimeters. I think that one of my main features will be tenderness. So if I press the probe, how the child or how the patient will react to my examination. If it's reacting with the pain or discomfort, then I will document it in my report and say this is suggestive of appendicitis. If exactly is the same scenario, slightly thickened appendix, 6 millimeters, a lot of lymph nodes, but there are no tenderness, I will say that this is probably not appendicitis. It's just kind of being a clinical doctor. We are all clinical radiologists, so we need to take this one back. If, however, I'm not sure what it is, I will recommend to scan the patient within 24 or 48 hours.
Okay, so we have a question from Nanika who asks, you had shown vacuolated appearance in vasculitis. Is it pathognomic? He has seen this in 2 patients with HIV/AIDS. So is this vacuolated appearance in vasculitis specific to it and pathognomic to it?
I don't have much experience with scanning this patient with HIV and vasculitis, but I do understand that this is very often the common scenario and the common presentation in these patients. And you can definitely see very diffuse edema in the bowel wall in the patient with the vasculitis.
Okay. We have an interesting question from Claire, who asked, we are increasingly being asked to use ultrasound for diagnosis and follow-up of constipation and fecal impaction now. And tips, and what is your definition of a dilated rectum? It would depend on age, of course. So any experience, at least we are not doing ultrasound for constipation or fecal impaction as of now. What about you, Joanna?
Now I don't. We are not doing ultrasound for this examination, for this indication. This should be a clinical diagnosis of the constipation, and if it's the real, we will probably we will go fluoroscopy and we will do the lower contrast study if they really worry about something. If they need to exclude all of the changes like a Hirschsprung disease and everything. So very often they will just do it with the colonoscopy and taking the biopsies. We don't do the ultrasound for constipation.
Yeah. How can we tell the difference between a localized perforation on ultrasound and a fistula? This is from Helen.
I think that this is the same really. It's just a different name because both fistula and the perforation is the definition is the defect within the wall of the bowel, extending through all layers and connecting the lumen with the outside. So if it's the fistula, if you have a long-standing chronic disease like a Crohn's disease, we will be talking about the fistula. If it's more acute and infected changes, we will be talking about the abscess, but it's exactly the same pathology, underlying pathology.
Okay. So how to differentiate mucocele appendix from appendicitis on ultrasound? That's a tricky one.
It's a very, very difficult. I'm not sure. Right, with the mucocele, that's a very tricky question because in the normal physiological scenario, we can find the fluid, we can find the air, we can have a fecal material within the appendix, and this is described as a normal physiological finding. So having a fluid within the appendix can be normal or it can be abnormal. And again, the mucocele can have a very thickened and abnormal wall. So this is the same in both. In the mucocele, you won't have a changes in the adjacent mesentery and this very hyperechoic fat. But the same in the very early appendicitis, you won't have these changes. So I don't think that we can make the differential diagnosis between the early appendicitis and the mucocele.
Yeah. So Elim Mann wants to know, when scanning preterm neonates, for how long on an average would you observe for bowel peristalsis before you conclude that it's absent?
I don't think that you need to do it for the very long time, because the bowel peristalsis should be there all the time. So if you leave your probe for a minute, you will have an idea if the bowel is moving or not. One word of conscience, just be really careful that if you push your probe too much, if you apply too much pressure, then you won't see the peristalsis very easily. So you can make the peristalsis worse. So always put a lot of jelly on the patient's skin and then don't apply pressure looking at the peristalsis.
Okay. Ahmed Mohammed asks, how can we diagnose appendicular mass from appendicular carcinoid tumor?
I don't think that we can make the decision on the base of the ultrasound. On the base of the ultrasound, we will see a soft tissue lesion there, and that's what we will do with the imaging. Then we will do the different tests, as I show you, probably the MRI, and then it's a really pathological diagnosis, not the imaging diagnosis.
Okay. Liska wants to know, what is the thickness of bowel wall in small bowel and large bowel, and what is the upper limit of normal?
Right. That's a really good, difficult question, because as I showed you before, there are different structure of the different part of the bowel. And the bowel will look different. If the bowel is collapsed, then it just looks slightly more thickened than if the bowel is distended and filled with fluid. A lot of authors recommend measuring the thickness of the bowel in the longitudinal scan, especially of the large bowel. What is approved now, that the small bowel, the normal thickness is between 1.5 to 2 millimeters. But in several publications, people say that if the loop of the bowel, if the lumen is collapsed, we can go down to up to 3 millimeters. Large bowel is slightly thicker, so the normal colonic wall is between 3 and 4 millimeters. But again, be very careful if the lumen is collapsed.
Okay. There's a namesake amongst the audience, Joanna. She's Joanna Mrose, who wants to know, please answer my question. I've asked how to manage the emergency ultrasound examination in cases like cecal volvulus of a child with 2 years of age cannot take the fluid or IVs and distinguish it from a Meckel's diverticulum. There is blood in the stool, so cecal volvulus versus Meckel's diverticulum.
I don't think that we will be able to make this differential diagnosis using the ultrasound, because as I said before, ultrasound is not very specific and we can miss the Meckel's diverticulum. Sigmoid, we can look at the dilated loop of the bowel, and if it's starting from the right iliac fossa and we can see the twist around the cecum, then we can diagnose it, but again, we cannot be definite using the ultrasound. So in this situation, probably lower GI study, or if the child will tolerate, I will put it to MRI machine scan.
Okay. Maria wants to know, can we call enteritis fluid-filled small bowel loops, but without wall thickening? Just the dilated bowel loops, but there's no wall thickening. So can we call that as enteritis?
I don't think so, because the definition of the inflammatory process is the inflammatory reaction or infiltration through the loops of the bowel. So it needs to be wall thickening to call it enteritis.
Okay. So coming back to, I think, one of the questions we had earlier, one amongst the audience wants to know, is the risk of rupture perforation in possible appendicitis not a concern if we rescan the child after 2 days?
It is, but we always need to check. So in the beginning, when is the definite appendicitis? We will see it on the ultrasound. I'm saying that I will scan the child if it's very early appendicitis, or the diagnosis on the ultrasound it's not definite. Very often the appendicitis progressed slowly. So if you do it the examination 24 hours later, you will see the progression, but unlikely perforation. Again, we need to be guided by clinicians, because if the child is deteriorating very quickly or the inflammatory markers are rising very quickly, on the base of our report that is the early appendicitis or possible appendicitis, they should make the clinical decision of operate on this child without the repeating scan. So I think that it really depends a lot on the clinical presentation and the condition of the child.
All right. I think we've answered most of it, but we've got one left, I think. Can ultrasound help in children with suspected malrotation to do an ultrasound and see reversed SMV axis, or do you also go in for a upper GI contrast study?
Right. If I see a definite reversal of the position of SMA and SMV, I will diagnose that this is a malrotation and I won't progress any further. However, if the child is with the clinical symptoms suggestive of malrotation, I can't visualize the vessels very well because the artifacts from the gas or position is normal, but you still worry clinically, I will progress to the upper GI study.
Yeah, there are many, I'd just like to add here, there are many causes of altered SMV, SMA axis. So upper GI contrast study is the standard investigation imaging of choice. So there was another question amongst the audience, which I've just replied there in the chat box. So Maria wants to know, what is the principal difference between appendicitis and appendix plastron?
Appendicitis and?
Appendix plastron. Plastron. I've never heard the term, to be honest.
We don't use this terminology. So
yes, same here. All right. I think we are done. I don't see any other open question. There's a repeat question. How do we describe a phlegmon on ultrasound? I think this has already been answered earlier. So I think I'd like to thank you, Joanna, for an excellent talk and excellent interactive session and a lot of interested audience asking some very relevant and very interesting questions and opening up a new imaging algorithms for us to decipher later on. You can announce, I think, the next meeting again, and Sanjay can take over.
Yes. Yeah. Can I get the yeah? So the next talk is by Professor Stefanie Franchiabella from France, and she's going to speak about pediatric liver ultrasound. What do you need to look for? Dr. Franchiabella is a very well-known interventional radiologist who heads the department in University of Paris-Saclay. I'm very bad at French, so forgive that. But you can register here in advance. The next this talk that Dr. Kathleen Brown just gave will be rebroadcast on YouTube on March 27th at 2 a.m. Eastern, 7 a.m. GMT / UTC on YouTube, and then all these talks will be made available as recordings once the ultrasound sessions are completed, most likely in May. That's for the recording. People are asking about the recordings. And one more question about the CMEs that I've got repeatedly. We do not award CME or CPD points because we have so many organizations around the world. But we will get you a certificate, which your email will be a certificate, so you can use that as your certificate of attendance for these webinars. And please answer all your survey questions that you'll have, like a one or two question survey at the end of this to make sure that we are providing webinars of things of your choice. I will put the answer to the plastron question. Turns out it's a term used for abscesses. It's abscess formation that occurs when the appendix has the omentum around it. That's called plastron appendicitis. So that question's answered too.
Okay.
Yeah, thank you very much, everyone. Thanks to the moderator and the speaker for an excellent session, and all the people who participated so actively with your questions. Keep them coming. We are really appreciative of your attendance, and hopefully this is helping you. Thank you very much.